a practical exam is going to happen. That's why since last month and this month we are concentrating the presentation. As I in DNB surgical oncology, also MCS surgical oncology, two cases make or break. Everybody will mandatory get a head and neck case, usually oral cancer, GB cell curse, oral tongue cancer, but some head and neck cancer and one breast cancer. These two are the place where it is makes and breaks for you in practical. You are supposed to know almost everything because there is a basic bread and butter of surgical oncology. So we start off with a good oral cancer presentation. Our Ved is presenting this to discuss these two very senior eminent surgical oncologist professor. My students who decades are specialized and have a very good name and knowledge in head and neck. Professor A.K. Diwan sir from Rajiv Gandhi Cancer Institution, New Delhi. Sir is not new. He is our examiner. He has taken several classes for us, and in his busy schedule, he accepted to take this and take the time out for all of you. Welcome, sir. Thank you. Thank you. Then we have Dr. Saranidhu Ghosh, who is a very senior professor surgical oncology from Saroj Gupta Cancer Hospital, Calcutta, who run a good, robust DNB surgical oncology program. Very active member of a IASO academician and a very good teacher. So today the discussion would happen in both of them. After the case presentation, mock exam discussion is done by both experts. Professor A.K. Diwan sir has a very good module how to approach in practical pertaining to head and neck cancer, do's and don'ts, what should be covered, what should not be answered, what should be, how to approach it. So sir will give about 15 minutes of presentation. Then we'll have a Q&A session in the time allotted. Thank you very much, both of you, sir. And over to you, Ved. All the best.
Thank you, sir. Good morning, teachers. So I'll start with my presentation. Patient characteristics. My patient is 32 years of age, male, resident of Arwal, Bihar, who has received no formal education and is daily wage laborer by occupation, belongs to lower socioeconomic status. He presented with chief complaints of ulcer on left side of tongue for 2 months. History of genetic illness. My patient was apparently well 2 months back when he noticed an ulcer in the left side of tongue. It was insidious in onset, noticed while brushing his teeth, and gradually progressed from initial size of a small pea to the present size of 2 by 2 centimeters. It is not associated with pain. It is not associated with excessive salivation or decreased mouth opening. There is no history of sharp tooth or any other associated trauma, no history of difficulty in chewing, swallowing, or speech articulation, no history of any swelling in the neck or any history suggestive of distant metastasis. I'll proceed with my past history. There is no medical comorbidities, no history of any surgery in the past, there is no history of any known allergies. Personal history, the patient gives history of tobacco chewing for approximately 5 years, which he quit 2 months back. He has a history of consuming alcohol for 5 years on an average of 300 ml of whiskey per week, which he quit 2 months back. There is no history of tobacco smoking. There is no history of high-risk sexual behavior, and his sleep and appetite is normal. Family history, there is no history of any malignancy in any of the family members. So I'll summarize my history. He is 32-year male, non-tobacco chewer with history of alcohol intake, presented with 2 months history of non-healing painless progressive ulcer in the left side of the tongue, not associated with trauma or high-risk sexual behavior. So shall I continue with general physical condition?
Yes, you can continue.
Ask him.
You can continue with the general physical examination.
Yes, sir. Patient is conscious, cooperative, inbuilt, and well nourished. He is well oriented to person, place, and time. His ECOG performance status is 1. Patient height and weight corresponds to BMI of 21.45 kg per meter square. There is no pallor, icterus cyanosis, clubbing, dehydration, lymphadenopathy, and pedal edema. His pulse rate is 78 per minute, regular, measured in right radial artery. Blood pressure is 130 by 80, measured in right arm in supine position. Respiratory rate is 18 beats per minute, regular. He is of febrile touch, temperature being 98.6 Fahrenheit. So I'll proceed with my local examination. On inspection, the facial symmetry is normal. Mouth opening is 4 fingers. No missing or loose or sharp teeth. Orodental hygiene is fair with no halitosis. Some visible nicotine stains on teeth noted. Continuing with inspection, also noted in left lateral anterior tongue of side.
Dr. Ved, Dr. Ved,
Yes, sir.
in inspection, you have not said about any leukoplekic patch or anything in that mouth. Any
Yes, sir.
leukoplekic or erythroplekic patch anywhere in the mouth, you have not mentioned in your inspection.
Yes, sir. I'm still continuing inspection, sir.
Okay.
Also noted in the left lateral anterior tongue of side 3 by 2 centimeter, which is oval in shape, irregular margin, everted edge, mainly located on the ventral surface of the tongue, 1.5 centimeter from the teeth and 3 centimeters from the circumvallate papillae. The ulcer is abutting the adjacent mucosa overlying the floor of mouth. However, dorsal surface of the tongue appears to be free. There is no visible lead or slump overlying the ulcer. Tongue protrusion is unrestricted. Rest of the oral subsides and neck appear normal. So this is the clinical image of my patient. On palpation, there is no tenderness present. Inspectory findings confirm mouth opening is 4 centimeter. Also noted in the left lateral anterior tongue of size 3 by 2 centimeter, which is oval in shape, irregular margin, everted edge, mainly located on the ventral surface of the tongue, 1.5 centimeter from the tip and 3 centimeter from the circumvallate papillae with indurated base. On bidigital examination, the induration is approximately 0.5 centimeter thick. The ulcer is mobile over the underlying muscle of tongue and floor of mouth. The ulcer doesn't bleed to touch. There is no sharp or loose tip felt. The rest of the oral subsides felt normal.
What do you mean by mouth opening 4 centimeter?
So it is adequate mouth opening.
Now, how do you measure that 4 centimeter?
Inter-incisor distance, sir. In the dented patient, it is inter-incisor distance, while in edentulous patient, it is interalveolar distance.
How do you know it's 4 centimeter? It's not 5 centimeter. It's not 3 centimeter.
So we use measuring tape, sir, for that, or we can use finger and then corresponding to the measuring tape.
Okay, proceed.
Carry on. Carry on.
On neck examination, there is no palpable neck nodes. Systemic examination was essentially normal. So I'll proceed with summary of my case. He is 32-year male, non-tobacco chewer with history of alcohol intake, presented with 2 months history of non-healing painless progressive ulcer in the left side of the tongue. The general examination was essentially normal. The local examination of oral cavity showed ulcer in the left lateral anterior tongue of size 3 by 2 centimeter, which is oval in shape, irregular margin, everted edge, mainly located on the ventral surface of the anterior tongue, 1.5 centimeter from the tip and 3 centimeter from the circumvallate papillae, with indurated base of approximately 0.5 centimeter thick on bidigital examination.
Is it necessary to examine the cranial nerves? Some cranial nerves related to the oral region, tongue, or something like that. Or have you examined any function of the cranial nerves when you are dealing with a case of carcinoma tongue?
Sir, The facial symmetry is the facial symmetry is normal, sir. So I asked it because there can be a deviation of the angle of mouth because of enlargement of the level 1B lymph node, which can involve the marginal mandibular nerve.
Marginal mandibular nerve. Marginal mandibular nerve, is it a cranial nerve which you need to examine?
No, sir, it is a branch of the facial nerve, sir.
Yes, but that is quite a distance from the lesion, or
Yes, sir.
the track of the marginal mandibular nerve goes along the neck and then enters into the angle of the mouth. So any other than facial nerve, marginal mandibular nerve?
In this case, it is a very small tumor, sir, but we have to examine for the hypoglossal nerve and the spiral accessory nerve, all these cranial nerves can be examined.
So you need to mention about this. You need to mention about this nerve, their function, because even a small ulcer in the tongue with the involvement of the tongue muscles can cause some defects in the hypoglossal nerve function. Okay, proceed.
So my provisional diagnosis is malignant ulcer of left lateral border of the anterior tongue, clinically T2 and 0 and X.
Any differential diagnosis?
So at this point of time, I would preferably keep this as my first diagnosis.
Okay, accepted. But you must have some differential diagnosis in the back of your mouth. So, especially in examinations like this, you must have some knowledge about the differential diagnosis.
Yes, sir. It can be painless because it is painless progressive ulcer. It can be dental ulcer.
Dental ulcer is not painless. Dental ulcer is painful.
Syphilitic ulcer, tubercular ulcer.
Don't comment about syphilitic ulcer in this phase. There is no syphilis case seen. Yes, it can be traumatic ulcer, that is dental ulcer, or it can be an infective ulcer. Infective ulcer means it can be tuberculosis, it can be any type of infection. Why T2?
Because the size is less than 4 centimeters, 3 by 2 centimeters.
What is T2?
T2, when the size of the tumor is between 2 to 4 centimeters, or depth of invasion is between 5 to 10 mm.
So how do you access the depth of invasion clinically?
So clinically, we do bi-digital examination, especially for tongue and in some cases of mucosa, where we feel the invasion. And also we can use imaging, sir, because it is an extension of clinical examination, MRI, on which we can assess the depth of invasion.
Is depth of invasion a clinical? Can you measure the depth of invasion clinically, or it requires, it is done mainly post-operatively or histopathologically?
It is mainly histopathological, sir, but
so by clinical examination and by radiology, you can have some idea of the depth of invasion, but it is not actual to find it out what is what.
Yes.
Dr. Diwan, you have a question, any?
No, I think this is the only difference. Clinically, it is always the size of the tumor.
Yes,
when you incorporate imaging, then you can talk of depth. You see, yes. When you do the MRI, you know the depth. You have a three-dimensional view, then you can add depth of invasion. Okay, but I agree with you. It is basically the histology which gives you actual TNM classic TNN. Carry on.
So what will be the next stage?
Yes, sir. I would like to confirm my diagnosis, sir.
Yes.
By doing biopsy of the lesion, tongue lesion.
Do you want imaging before biopsy or after biopsy? And what is that imaging?
first, I would like to confirm my diagnosis in this case, sir.
And then
I will do
imaging.
biopsy, yes, sir, and then imaging. Imaging, I will be using contrast enhanced MRI of the tongue and neck, including sections from the base of the skull to clarity.
In this small T2 image, T2 lesion, what will happen if you do MRI after taking biopsy? And what is the advantage of doing it before doing the biopsy?
Sir, there is one concern that in a small tumor, when we take biopsy before imaging, there can be edema and that will cause artifact or enhanced lesion on MRI imaging, sir. But when we do after imaging,
So if you have an enhanced lesion on the MRI, is that proper to do it, or you need to do an MRI prior to biopsy and then go for MRI biopsy?
Sir, can do imaging before also, sir. But because this is a small lesion, I would like to confirm the diagnosis first, sir.
What other investigation you can do other than MRI, and what are the disadvantages of MRI in oral tongue lesion? There are many advantages. What are the advantages of MRI, and what are the disadvantages of MRI?
Disadvantage is that it is not readily available, sir. It is costly. There is when the patient is having MRI non-compatible pacemaker, then it is contraindicated in those patients, and it is not suitable for identifying the bone lesions, sir. Bone lesions.
MRI, the one thing also is there, if the patient have any filling in the teeth, that can cause an artifact in MRI. So, what are the advantages of MRI?
The advantage, we can know the extent of the disease. We can, anterior extent, whether it posterior extent, whether it is involving medially. We can know the perineal invasion. We can know the volume of resection, whether there is involvement of cervical lymph nodes or not.
You have gone to the neck again. In head and neck, in the face, in this tongue lesion.
Okay, sir. Yes, sir. If there is any involvement of floor of mouth.
That is, you have said, is involvement. You have, or you can also know about not perineal invasion,
marrow involvement.
Marrow involvement and invasion of the nerve. It is not perineal invasion. I told you there are many cranial nerves going in the region
foramen oval, sir, involvement or enlargement, sir.
Dr. Ved Prakash, should we be doing an MRI in T1, T2 lesion of
Yes, that's the next question.
Yes, sir.
Is it a must to do an MRI in T1, T2 lesion, or you can straight away go ahead with surgery?
It is not a must, sir, but it will help us to plan the resection.
What will you do in T1 lesion of oral cancer, T1 lesion of tongue? No nodes.
You can straight away go ahead with surgery, sir.
Any other investigation would you like to do, which is much simpler?
Ultrasound of the neck can be done, sir.
Yes. Okay. T1, T2 is not mandatory to do an MRI imaging. You can straight away plan your treatment.
So now still you will go for biopsy and then imaging. Is it so?
Dr. Saab, I think you're not audible.
Yes,
Hello.
sir. Yes, sir.
So you said that you will go for a biopsy and then an MRI. Is it true? Is it like that? It's still like that, or it is different?
Sir, in very small tumors, sir, we can first do imaging and then do biopsy. But in this case, sir, because it is a 2 centimeter size tumor, I would like to do biopsy first, sir, and then
If the MRI is not available, what other investigation you can use?
if MRI is not available, sir, then I will access it under clinical examination, sir, like evaluation under anesthesia is also while doing surgery, sir, to plan the extent of resection. And for neck, I will do ultrasound of the neck. And then I'll
So if you don't have an MRI, you are not going to do a CBCT of the head and neck region, face and neck region, or is it not required? If you don't have an MRI, or the patient is not suitable for MRI, or patient is something complains about MRI, or side effects in the region, would you recommend CECT of the neck and face region?
So for small tumors like this, sir, CT scan will not help much, sir.
If CT scan cannot help, why do you think the MRI will help you?
Because MRI is a better modality for delineation of soft tissue lesions.
But it has some disadvantages and it's not available everywhere, especially in the country like India.
For locally advanced tumors, sir, we can go ahead.
No, yeah, we are talking about this tumor. This is not locally advanced tumor. This is a small tumor which is easily accessible.
Yes.
Or do you want to do anything like CT chest, PET CT scan now in this situation?
No, sir.
When are you going to advise a CT chest in a case of carcinoma tongue? And
yes, sir, when there is bulky nodal disease, anterior and 3, and when the lower cervical level of lymph nodes are enlarged, then I will ask for a CT chest. Otherwise, I will go ahead with chest X-ray, sir.
What do you mean by lower cervical?
Level 3 and 4, sir.
Is that lower cervical?
Lateral cervical. Lateral lower cervical.
Okay, then regarding PET scan, your opinion? Instead of doing CT of the head, neck region and chest, you can go straight for PET scan. Do you think so? It's right?
So not upfront, sir. We do it for recurrent disease or during follow-up when we suspect there is a recurrence of disease.
Dr. Shah, is there any role for a PET scan in CA tongue? Not in this case, but otherwise CA tongue. Is there any role for PET scan?
The role is for recurrent disease, sir, or when there is bulky nodal disease, bilateral nodal disease, then we can. And when the extent is posteriorly up to vallecula or.
No, you are saying up to vallecula is a different disease altogether.
Yes.
Oral tongue.
You limit yourself to anterior two-thirds of the tongue only.
Okay. So when it is involving the anterior floor of mouth.
You see, whenever you have bulky nodal disease, multiple level of nodes, lower group of nodes or contralateral nodes. Okay. And T4 disease, you must have a PET scan. Am I right?
Yes, sir.
Okay. Carry on.
The biopsy result of my patient's squamous cell carcinoma, grade 2.
Dr. Shah, suppose the report says inflammatory, no evidence of malignancy, and it shows only hyperplasia and some inflammatory cells. What will you do? You have done an incisional biopsy.
Then I'll counsel the patient because the lesion is non-healing and progressive ulcer. I'll counsel him for excision of the lesion.
If you want to do a repeat biopsy?
Pardon, sir?
You want to do a repeat biopsy or you will straight away go? What do you want to do? You want to repeat the biopsy or straight away go for wide local excision?
We can do one more repeat biopsy if the biopsy is doubtful, sir. Previous biopsy is doubtful.
Okay.
Other, so 2 times biopsy negative will be an indication for excisional biopsy.
Excision. Okay. Is there any role for frozen section in this situation?
Frozen section has no much role, sir, in oral cancer.
No role.
There is role, sir, but no much role, sir. When we can do, sir, but if we have option of doing repeat biopsy, then we go ahead with repeat biopsy first.
Both the times biopsy has come negative.
Yes, sir.
You
Then
will
one
excise this lesion because the lesion has been persisting for more than 3 months. You will in any way excise this lesion, maybe do a frozen section at same time and take it out. Okay?
Yes.
Okay. Carry on. This is squamous cell carcinoma. Then
Great. Yes, sir. This is the imaging, sir.
You have taken a biopsy from the margin as is usual. But is there any comment about the depth of invasion in your biopsy report?
It was not commented.
Do you think it should be commented? And how it will change your management protocol?
Sir, the depth of invasion will help in T staging, sir. So, if possible, it can be commented, sir. But for that, the entire depth should be taken into consideration. Right?
How do you do the biopsy proper?
So we take the biopsy from the edge of the tumor. We
Which
take
is anterior, posterior, medial, lateral? Which is
lateral edge, sir.
lateral edge, not anterior edge. The thing is that you must take a biopsy from that region which will not alter your margins in the later surgery. So it is better to be taken from the anterior mucocutaneous junction involving a part of the normal tongue tissue and the everted margins from the tongue ulcer.
It should be narrow, deep, and there should be a bleeding. It should sink in the formalin bottle.
Dr. Saab, when do you do a punch biopsy? When do you do an incisional biopsy?
Punch biopsy when it is ulcerative lesion, sir.
Okay.
When the tumor is bulky and it is ulcerative. Incisional biopsy when it is ulcerative lesion, where we can't easily take punch, sir.
Punch is all right. Incisional biopsy, when do you do incisional?
When it is ulcerated lesion, sir.
What are the different types of lesions?
What do you do? Verrucous carcinoma, what do you do? If there is a verrucous lesion on the tongue, what type of biopsy will you take? Punch or incisional?
Incisional, sir.
Huh?
Incisional, sir.
Good, good. Carry on.
This is T2 weighted image of MRI tongue, which is showing hyper intense lesion on the lateral aspect of anterior tongue, which is almost 2 centimeters away from the tip of the tongue and almost 4 centimeters from the base of the tongue. It is not crossing the midline. And
what is the report of your radiologist in this? What is the size of the lesion? Looks quite small.
Yes, sir. 16 by 8 mm of size.
You said 3 centimeter by 2 centimeter. That is why I'm saying it looks quite small. Clinically, also, it appeared to be quite small. Am I right, Dr. Ghosh?
Yes, it is coming to be T1 tumor.
Yes, yes.
So in a T1 tumor, if you take a biopsy and then a second operation, it will again become T2 tumor. So why not do a wide local three-dimensional excision and then follow it up? Yes, and I want your comment. So are you going to do biopsy again first and then wide local excision, or you defer, as Dr. Professor Diwan said, do it on the table, frozen section, and etc.
Yes, sir. We can do that also.
No, one biopsy is enough. If it is negative or inconclusive, go ahead with local excision, wide local excision. Okay? Don't do a repeat biopsy in such a small lesion. Carry on.
Then what did
MRI
you do?
says T1 lesion and no significant nodes. How will you proceed further?
I'll first counsel the patient, sir. It is G1 and 0 that is early stage tumor, stage 1. So I'll counsel the patient for de-addiction and the option of surgery, that is wide local excision and neck dissection. And also I'll counsel for swallowing and speech rehabilitation. So in the surgery of the primary, I'll be doing wide local excision, partial glossectomy, and neck dissection. I'll prefer to do selective neck dissection 1 to 4.
You have tumor boards or multidisciplinary clinics in your hospital.
Yes, sir.
Would you like to discuss case?
So here the protocol is
Okay.
standard.
You have a standard protocol. You don't want to discuss.
So all patients of this group come and do surgery. Is there any role of radiotherapy, brachytherapy, whatever it is like that? That's what comes in when the patient doesn't want to do a surgery on tongue.
Yes, sir. If it is basically a surgical disease, sir, but if patient doesn't want for surgery and want his speech and swallowing to be persistent, then we can give him options of brachytherapy also, sir. Brachytherapy to the tongue and EBRT to the neck.
Do you know any statistics of dealing with surgery or dealing with radiotherapy?
Yes. Yes, sir. For early tumor, there is National Cancer Database by Ellis et al., who has proven that surgery has better outcome compared to radiotherapy. And also there are data from the Pinsa et al. From MSKCC. And also from
Dr. Saab, where will you prefer surgery and where will you prefer radiation? T1, N0. Where will you prefer surgery over radiation?
For anterior tongue, we prefer surgery, sir, but for posterior tongue, T1 lesion, we'll prefer radiation.
Anything else? If a patient has got submucous fibrosis, what will you prefer? Prefer surgery.
Sir,
Young patient prefer surgery. Okay. So in this particular case, he is 32 years. You are not going to affect his function much. It is a T1 lesion. Prefer surgery. He doesn't have any submucous fibrosis. His mouth opening is very good. You can do intraoral resection and do a primary closure. Okay. Sir, carry on. Sir.
Hello.
Dr. Ghosh.
Yes.
Next question. Can we proceed?
Yes, you can proceed. After doing on wide local excision of the tongue, will you deal with, in such case of a stage 1 disease, will you deal with the neck? You said you will deal with the neck 1 to level 4.
Yes, sir. Because it is tongue cancer, sir, there is high incidence of metastasis, and it is proven by N0 trial by TMS and Institute et al. That there is better overall survival and disease-free survival even for N0 net by doing electric net dissection.
Now, after doing surgery, as Dr. Diwan said, you will go for a primary closure, put in flaps. What do you do? What are the different ways of correcting the defect made by wide local excision of the tongue? I am asking you.
So we can do primary closure or use local regional flap like we can use infra-high flap, submental flap, and also we can
infra-higher.
Yes, sir.
Infra-higher flap.
Yes, sir.
How is it done? From where is he taking the skin?
Just below the higher bones are about cartilage, depending on the size of the defect.
Is that differently named as sublingual region flap or submental flap?
The submental flap is above the higher bones. Yeah. There you can address the level 1A.
Okay, you have addressed the neck and you have done a wide local excision of the tongue. Then
this is the photo image of the patient.
so it seems that you have pulled something else there. You have put in a flap instead of doing a primary closure.
Yes, sir.
And your neck incision shows you have gone to the level 5, then limit yourself to level 4 only. It's not matching with your words you're saying.
We did extended supramo hand.
Professor Diwan, comments?
I think I'll talk about this. I have prepared a small presentation. How do you repair depending on the defect which we create? I have never done any infra-wide.
Yes, that's true.
And we have done in the past nasolabial flaps for little tongue defects and submental flaps, agreed. And this appears to be a case where primary closure was possible. I don't know whether it is required to fill this defect.
Dr. Shah, what are the ways by which you can repair the defect of the tongue? Small
Yes, sir.
lesion?
For a small lesion, we can do primary closure, sir. When the defect is less than 30%, then we can do a primary closure. Otherwise, if the defect is more than 30%, we'll go ahead with local renal flap like we discussed, the submental flap, nasolabial flap, high flap, all these can be even FAM flap, that is facial artery, mucosal, mucosal flap can be used. High FAM flap, high landed mucosal. And free flap like.
What will happen if you just leave it to field or secondary intention?
So, that is also an option, sir, when it's very small, like 0.5 or 1 centimeter, then it will heal, sir, it will heal by second intention.
Now, suppose you have, if this lesion has crossed the midline, how will your plan of management change? This is a small lesion, T1 lesion in the lateral margin of tongue. But if it is a big lesion, T3 lesion or and has crossed the midline of the tongue to the opposite side, what difference you will accept, you need to do for your planning of treatment?
So, we need to address the bilateral neck and also the extent of dissection primary dissection will increase. We may have to resort to subtotal glossectomy or compartmental glossectomy, sir.
So, if you go for subtotal glossectomy, how do you reconstruct the defect now?
For subtotal glossectomy, sir, we need a bulk flap like anterolateral thigh, three anterolateral thigh flap.
Why do you require a bulky flap? Why not a simple cover? If you wish, you can do it with split thickness also. Why were you looking for a bulky bulky flap?
Because the bulk of muscle will help in swallowing. If it is
Is
bulky.
it so? Is it so the material which you have put in has a muscle and the muscle acts like that of tongue, or it is just a...
No, it is aerodynamic, sir. It is aerodynamic.
So if it is aerodynamic, why are you looking for a bulk? Okay.
Because for swallowing rehabilitation can be done, sir. We may teach him for swallowing rehabilitation.
Okay, proceed. What next are you going to do?
We'll wait for histopathological report, sir, and then according to histopathological report, we'll be giving adjuvant treatment.
What histopathological report do you expect in this patient, or do you have the histopathological report with you?
No, sir, it was operated on Monday, sir, so I do not have histopathological reports actually.
Suppose the report comes as depth of invasion is 4 mm and this is 1.6 into 1 centimeter size tumor and no high risk feature. No PNI, no LVI, WPI is 3. How will you manage this case?
So, then I'll, if the patient is compliant and is can undergo close surveillance, then I will observe the neck, sir, and keep him under close surveillance. Provided
You have addressed the neck. You have already addressed the neck.
Neck is only operated.
So I will not give him adjuvant radiotherapy, sir.
Okay.
There is no high risk feature and the patient is compliant.
Suppose perineural invasion is present, which is intratumoral. Intratumoral perineural invasion present.
Yes, sir.
You know, there is something like intratumoral perineural invasion and extratumoral perineural invasion.
Yes, sir.
So if it is intratumoral PNI present, rest everything same, what will you do? You can still observe these patients. Unless it is extratumoral PNI, then you will give adjuvant radiation. Okay?
Yes.
When will you give chemotherapy in addition to radiation?
So when there is extranodal extension and positive margin, then you add.
Okay, yes. Positive margin, what do you mean by positive margin?
When it is less than 1 mm, sir. When the tumor
When it is
invasion is
close margin,
less than 5 mm is close margin.
okay. How much margin do you take operatively?
We take, sir, 1 centimeter across on a stressed margin, sir, for operatively. Beyond the individual.
Good, good. Dr. Ghosh, can we, you have something more to say?
No, you can go for your lecture because the time is very near.
Yes. Dr. Somshekhar, do I have the permission to go ahead? Anji, Navneet ji, can I proceed?
You proceed. They have all gone to some place or other. You proceed.
I need permission to share. They're not. Dr. Somshekhar? So this is for the benefit of all the students. How do they actually present a oral cancer case in exam, and what do we expect as an examiner? Many things I have omitted. I have just highlighted few of the things which students talk about. And I will also tell you some of the frequently asked questions from from the examiner. So this is how one of the candidates presented an exam. He says, my case is Krishan Lal, who presented with ulceroproliferative growth of left side tongue. There is history of severe pain in the tongue, which has been increasing in intensity since 2 months. There is no history of dysphagia or dysphonia. There is no history of jaundice. There is no history of dyspnea. There is no history of urinary symptoms. There is no history of neurological problem. No addictions. No history of diabetes. No history of hypertension. No history of tuberculosis. No family history of cancer. Now, you may think that he has covered almost everything. But if you see, there's no need to talk about name. My case is Krishna. All these red are wrong words. Ulceroproliferative. Patient will not tell you that he's got ulceroproliferative lesion in the neck, in the mouth. Since invariably I have found people talking don't know whether to use the word since or for. Then dysphagia, dysphonia. These are not symptoms of patient. Jaundice, dyspnea. And here, what is the significance of urinary symptoms? Something which the examiner expects you to elaborate, you just make it very small. No addictions. What is no addictions? We expect you to tell us about the smoking habits, tobacco chewing habits, alcohol, because these are one of the few of the predisposing factors. So don't just say no addictions. Then why do you repeat the word there is no history, there is no history, there is no history? Say in one sentence, no comorbidities. You see, something which needs to be highlighted should be highlighted. Other could be just silent words. Okay? This is what is expected. This is what is expected from you. Say 50-year man hails from Etawah, UP, teacher by profession. So you have conveyed his profession, from where is he coming, what is he doing. He is a reformed smoker and continues smokeless tobacco. He is a vegetarian, fond of coffee, tea, not habituated to alcohol. He presented in our OPD on this date, or you can put some duration, with complaints of non-healing ulcer, left side of tongue. Pain in the tongue and ear has started 15 days back. He complains of excessive salivation. He also reports decreased mouth opening for last 2 years. He has difficulty in swallowing, speaking due to pain. No history of bleeding from mouth, swelling in the neck. No history of loss of weight, loss of appetite, cough, bony pain. Dr. Saha said, no history suggestive of metastatic disease. Fine, that is acceptable. But I think it is worth mentioning that loss of weight and loss of appetite should be mentioned in such situations. He is non-diabetic, normotensive, euthyroid, not on any medication, treated for pulmonary coughs in childhood, not allergic to any medication, no major illness in recent past. He is unmarried. Married, unmarried has got a significance here, because you know how much is the social support he has got in treatment. So no family history of any type of cancer. Okay. Now coming on to the general physical examination. This is how the students tell us: conscious, well-oriented in space and time, pulse, BP, respiratory rate, normal. JBP not raised, no pallor, no jaundice, no cyanosis, no pedal edema, no positive finding, no significant negative finding. Systemic examination, normal. So, anything wrong here? This is what we expect. Conscious, in lot of pain, holding his ear with tilted head. See, many times you will find them holding their head and doing like this. So mention that. Performance status must be mentioned. No swelling of face or asymmetry of face. Then you talk about the vitals. Stridor is there or not. Pallor, jaundice, cyanosis, pedal edema, nails, halitosis. I am glad Dr. Saab mentioned about the halitosis. Most of the candidates, they miss halitosis. No obvious skin lesions. These are important. Maybe he's got some satellite nodules in the neck swelling, evidence of recent weight loss. He's lost weight, you may find him emaciated. So you will be able to judge, and you must mention in exam that patient has he lost weight recently. Any post-radiation changes, skin changes, woody neck. If a patient has received radiation in the past, you must mention. Maybe the hair distribution. He's got very sparse hair on half of the face. Alopecia. Is he hearing well? कई बार वो कान लगाकर आपके पास आते हैं, वो ऐसे सुनते हैं. Maybe he has received radiation, and post radiation he has got some hearing problem. Carrying water bottle because of xerostomia. Many patients who have received radiation may be carrying water bottle. So you must mention this also. This is also a part of the general physical examination. So next part is local examination. There is 3 into 3 centimeter ulcer proliferative growth on left lateral border tongue. Ulcer is hard, raised margins, bleeds on touch. There is tenderness on examination. Rest of the oral cavity is normal. Neck 2.5 into 2 centimeter. Level 2 node which is hard in consistency. There is fullness at level 4 and no systemic lymphadenopathy. So what is wrong here? So now, sorry. There is 3 into 3 centimeter. Sorry, I think I have repeated this. Yes. What we expect is divide this into inspection, palpation. Nice, Dr. Saad did it. Inspection separately and palpation separately. But you must start from face of a person. Don't just jump onto the tongue. Facial asymmetry, obvious mass on face or neck, any nodule or ulcer on the neck. If he is wearing any denture, is he dentate? Is he edentulous? Is he wearing partial dentures? They must be removed if it is possible. Then trismus, what is the grade of trismus? Has he got halitosis? Has he got oral submucous fibrosis? Ankyloglossia? Tip of the tongue can be protruded or not? How much centimeter beyond incisors? What is the orodental hygiene? Has he got sharp teeth? Is he wearing any dentures? All these should come before you start with description of tongue lesion. Okay? So there is 3 into 3 centimeter ulcerated lesion covered with slough on left lateral border of tongue, extending onto floor of mouth, not extending towards base tongue. Mind you, this is inspection. So you can't talk of whether it is crossing midline or not. Tip of tongue is free, no ankyloglossia, no deviation of tongue on protrusion of tongue, no leukoplakia or erythroplakia in whole of oral cavity. Very good point, Dr. Ghosh pointed out that leukoplakia, erythroplakia around the lesion or in rest of the oral cavity must be mentioned. Patient has black hairy dorsum of tongue, under surface of tongue is normal, and neck swelling in some area, if you can see size, site, any lesion on the neck should be mentioned. These are a part of inspection. And frequently asked question. Now the examiner will stop you here. Most of the time, if you have talked of the history and maybe inspection or even before that, examiner might ask you these questions. Trismus, what are the grades? What are the causes of trismus? Oral submucous fibrosis, what are the causes? What is the treatment? And ankyloglossia, what are the causes? Name the intrinsic and extrinsic muscles of tongue. So be ready with all the muscles. People say stylohyoid as extrinsic muscle. That is wrong. Please be clear what are the 4 extrinsic muscles of tongue. Relation to T status, ankyloglossia, is it related? Cause of deviation of tongue on protrusion of tongue. Cause of hairy dorsum tongue. If there are fissures on the tongue, What are the transverse fissures? They are usually congenital, vertical, or could be syphilitic. We don't see it now. Otalgia, very favorite question with the examiners. What are the causes of otalgia and what are the neural pathways? Mind you, for oral tongue lesions, it is the mandibular nerve which is involved and its branches. And for base tongue and the oropharynx lesions, it is the glossopharyngeal nerve, okay, and its branches. Neck swelling in which area? This is very important, which I want to highlight. People say that node felt at level 3. You see, when you are doing a clinical examination, name the lymph node. Say jugulodigastric, submandibular, upper deep cervical, mid-jugular, lower jugular, supraclavicular, post. Don't talk of triangles. Okay? Sorry, don't talk of levels. Now coming on to the palpation. So trismus grade 2 permits palpation of oral cavity. Whether you can put your finger inside the mouth or not. Tough band in buccal mucosa due to OSMM. There is ankyloglossia. There is 3 by 5 centimeter ulcero-infiltrative growth. Mind you, this is infiltrative growth in my case. So the measurement is much more than what you inspected. So lesion covered with slough on left lateral border tongue, extending onto floor of mouth, bleeds on touch. Base tongue and tip of tongue are free. You must mention the points which are going to help you in further management, like tip of tongue, base of tongue, whether it is crossing midline or not, whether floor of mouth is involved or not, whether it is reaching onto the mandible or not. So induration not crossing midline, there are no satellite nodules felt in the tongue. You may find some satellite nodules. Minimum induration in floor of mouth on bimanual palpation. You must examine the TM joint, do an indirect laryngoscopy, at least show in front of the examiner that you know how to do an IDL. Neck, one side at a time, standing behind the patient, mention the site, name, site, size, number, consistency, fixity, skin involvement, relation with vessels, if any, satellite nodules in neck or even chest. Other sites like axilla must be mentioned. Sometimes you find axillary nodes, incidentally. Systemic examination. So after the palpation, examiner might ask you what are the morphological types of oral cancer. Mind you, 50% of the students will always comment on ulceroproliferative growth. Every growth for them is ulceroproliferative. No, you must know what is ulceroproliferative, what is ulcerated, what is ulceroinfiltrative, and what is verrucous growth. I'll show you the photographs. Significance of involvement of tip and base involvement, base tongue involvement. This has got a bearing on the functionality of patient. If tip is involved, speech is affected. Base is involved, his swallowing gets affected. So you must counsel the patient when you are planning surgery, what is going to happen to the patient. So how will you counsel the patient preoperatively? Functions of pterygoids. I'm very fond of asking what are the functions of medial pterygoid, lateral pterygoid, and what are its attachments. When will you say the lesion is unresectable? What is unresectability? What is inoperability? Which morphological oral cancer has got the best outcome? Ulceroproliferative has got the best outcome. Differential diagnosis of tongue lesion, spread of tongue cancer, causes of macroglossia, and differential diagnosis of tongue ulcer, as Dr. Ghosh had asked this question to you. These are all proliferative lesions. Major bulk of the tumor is lying outside. This is ulcero-infiltrative growth. Much is inside. There is ankyloglossia. There is a small ulcerated lesion only. And this is a verrucous lesion. Looks like a jadi. So now the examiner will ask you, summarize your case. So you should be ready. You must have written in your case sheet or paper, how will you summarize the case? 50-year reformed smoker, tobacco chewer, teacher by profession, hails from UP, no comorbidities. He is reported with non-healing ulcer tongue for 3 months. He's got pain which is radiating to the ear for 15 days. No history of constitutional symptoms. You are given almost everything. You are given the diagnosis. Examination reveals trismus grade 2, OSMF, halitosis, partial dentures, 3 by 5 centimeter, also infiltrative growth, left lateral border tongue. Not crossing midline but extending onto floor of mouth, tip of tongue, base of tongue free, left submandibular node, size mobile, suspicious. So diagnosis is carcinoma, left lateral border of tongue, T3N1. Long-standing trismus, OSMF is positive, present, no comorbidities. So this summarizes your case. The next question from the examiner may be, how will you proceed further? What would you, then you must say that I would like to confirm my diagnosis by doing punch biopsy or incisional biopsy or whatever, depending on the lesion which you have. Then I will do the staging workup, MRI or CT, whatever in an oral case you want to do. Assess the general condition. Pre-anesthetic assessment after MSc discussion. MSc means multi-specialty clinic. And now the examiner says that the report comes as MDSCC, that is moderately differentiated squamous cell carcinoma, T3N1, left lateral border tongue. How will you manage further? So, how will you manage is, Dr. Somsekhar, I'll take 5 minutes more, I'll finish off. So,
Go ahead, sir. We have time. Go ahead.
Discuss in MSc or tumor board, pre-operative counseling you will do. You will discuss with him. Mind you, he's a teacher. He is afraid of surgery. He wants to preserve his voice. So you must tell him what is going to happen with surgery and what is going to happen with radiation plus chemo. What are the pros and cons and outcomes with each modality of treatment? Extent of surgery. How are you going to reconstruct? What is the duration of stay? What is the cost, post-op recovery? Possible outcome with each treatment, side effects of radiation, cost of treatment. If surgery is opted by patient, then what is prehabilitation? Every student now should know what is prehabilitation. It is pre-anesthetic assessment. You involve the cardiologist, you involve the dental surgeon, nutritionist, psychologist, speech and swallowing therapist. So it is actually the rehabilitation work which has started pre-operatively. That is prehabilitation. Okay? Admit a day before, arrange blood, consent, follow the ERAS protocol. I'm sure all the students know what is ERAS protocol. Enhanced recovery after surgery. You must know what is ERAS protocol. Now, few of the questions which are there, which might be asked from you. Why do you do an incisional biopsy? Why an MRI and not CT scan? What is puff cheek technique? How do you interpret an MRI? Role of PET scan, any need for metastatic workup? What is prehabilitation? What is ERAS protocol for head and neck cancers? Pre-operative counseling, functional deficits after surgery. That is a part of the counseling. He is a teacher, mind you. If you are going to resect his tip, not going to reconstruct, he is going to have quite effective speech. His speech will be affected. So patient is a teacher. He is keen on non-operative measures. So is there any option? How will you counsel this patient? So I'm not going to talk about it, but you must know how to interpret an MRI. This is next set of questions where when you have done very well in your exam, and this is the last actually set of questions, then you just passed and these are beyond passing. What is carbo load pre-operatively? This is a part of the ERAS protocol. How will the anesthetist intubate in case of a painful ulcer and in case he has got trismus? What surgery will you perform? What are the indications of elective tracheostomy? When will you do tracheostomy? How will you reconstruct this case? 3 by 5 centimeter reaching onto midline. How will you monitor the flap post-operatively? any head-on trial comparing surgery versus radiation plus chemo. What is the role of frozen section in this case? Suppose anterior margin comes positive during frozen section. What are the changes in TNM classification, 8th edition, which have occurred in recent past? What are the dietary instructions which you give in post-operative period when you discharge the patient or during radiation? What is the role of HPV in tongue cancers? Okay, and this is again last set. Discuss the approach to non-healing ulcer of tongue. Role of EUA, examination under anesthesia. How do you decide about type of reconstruction? Depending on the, you must know the type of glossectomies. There are 5 types of glossectomies, 1 to 5, depending on the defect which you create. How many grades of or types of defects are there, 1 to 4, you must know. So what do you expect to get in histopathology report from the pathologist? What is the expectation? What are the indications of post-operative radiation? What are the indications of chemoradiation? And what are the trials here? What is the role of immunotherapy in recurrent oral tongue cancer? You must know the details of DCF regime, triple drug regime, and what is the trial, tax. 2 trials are there. What are the indications? What is the dose? What are the side effects of cisplatin, carboplatin? What are the causes of death in recurrent tongue cancer? What is Keynote 048 study? What is extreme trial in oral cancer? What is CPS score when you are before you give immunotherapy? So these are some of the questions which you should be prepared for if you are preparing oral cancer. And I can assure you, you will get one oral cancer case. And if you are ready with these questions, and one other favorite question is what is metronomic therapy? People are very fond of asking metronomic therapy. So thank you. This is what I wanted to tell you, that that is how you should be prepared with an oral cancer case. Dr. Somshekhar.
Sir, you can open Q&A and chat box. Some questions are there. You can answer both of you. Dr. Ghosh, you can also open. There is a chat
Yes,
box
I'm
and
trying.
some questions are there.
I'm trying this. Nothing is coming up.
Should we say thickness in examination part? You see, it is difficult to assess thickness in clinical examination. So your clinical examination should actually talk of length, breadth, 2 dimensions. And that is the main problem with our TNM classification. TNM, where we talk of depth of invasion, is actually pathological. But if you have all the reports available with you, MRI is there, CT scan who was given some dimension, then you can talk of thickness in examination. Sir, Dr. Ghosh.
Yes. Yes. The thickness is. I agree to it, because I also asked a question to how do you know the depth of invasion? You cannot do it in the depth of invasion clinically. It is always a pathological depth of invasion. So either it is in clinical examination TNM, it is very difficult to comment about depth of invasion. It's only a rough estimate that this is likely to be a deeper lesion, or it is not likely to be a deeper lesion, superficial lesion.
When to address lymph nodes in lateralized primary of head and neck, what to say in exam? Yes, this is a very good question. You see, clinically node negative, ultrasound is negative, small lesion, T1, but they say that more than 4 mm depth, you must address the neck. In tongue and floor of mouth cases, even if it is T1 lesion, you must address the neck. They are notorious. the chances of lymph node metastasis are high even in N0 neck. Dr. Ghosh?
Yes, yes. Dr. De Cruz has already pointed out the role of neck dissection even in T1 neck.
Yes.
If you dealing with carcinoma tongue, it is not lip or anything like this. If you deal with carcinoma tongue, it's very, very dangerous. You all must at least do at least a supraomoid neck dissection.
Minimum 15 nodes as per AJCG. If less number dissected,
no, if you have properly done a neck dissection, it will be more than 15. Either there may be a fault in the pathological accrual of the nodes, or there is the neck dissection is not properly done.
clarify. Sentinel node, would you like to comment, sir?
Sentinel node has in head and neck thing. Sentinel node is not very popular. Neither it is very effective. Its value is not that very. What I say. It's not that very effective one. Means doing a sentinel node biopsy.
NACT in oral tongue, you see, whenever you have bulky nodal disease, it is more on nodes than anything else. If you have bulky nodal disease and contralateral neck nodes, lower level nodes, multiple nodes, better to give NACT. Although books don't write all this, but even in exam, if you say that I will give NACT in oral tongue for a bulky nodal disease, I will accept it. And most of the examiners will accept it. And but you should be ready about the primary, whether you are able to resect it or not. And you must read the types of glossectomies for your exam. Okay. If anybody is interested, I can post it here in the class itself. The types of glossectomies, types of defects created by resection, and how do you decide which type of reconstruction to be done. I have a slide made. I'll just post it to you. Sir, Dr. Ghosh?
Yes.
NACT in oral tongue.
NACT in oral tongue, the primary is borderline resectable. I'll coin it in this way that if it can be resected with margin free, but there is a nodes which is big enough or likely to be fixed, or then you can consider NACT. If the node decreases in size, if the tumor decreases in size, probably the chances of margin free excision will be much better. That is the role of NACT in tongue only.
Yes. Students say quite frequently in locally advanced oral cancers, I will give pre-op radiation. Please don't use the term pre-op. Previously, what we used to do, give 40 gray, 54 gray radiation, then do surgery. But nowadays,
it is no longer true.
Surgery, either it is surgery followed by radiation plus minus chemotherapy, or it is definitive radiation plus chemotherapy followed by salvage surgery.
Yes,
that's the term used. We don't use the term pre-operative radiation. So don't use the term pre-operative radiation. Okay?
Good, sir. It appears all the questions are answered. Thank you very much, lovely sir. Thank you very much, Diwan sir and Professor Ghosh sir. Excellent discussion and excellent compilation. And Ved, you did very well. Don't worry, you passed in exam. This is a tough case. Even if I present between two esteemed examiners, I'll fail. But beautiful you did. Fantastic. Thank you very much, both of you. Heartfelt thanks from students, myself, and
you will pass more than pass. Don't worry. You've done well.
Superb, sir. Excellent discussion. Thank you very much. And over to Navneet Singh ji.
Thank you.
Thank you very much, Dr. Ved Prakash for the presentation, and thank you very much, Professor Dr. A.K. Diwan, Professor Dr. Sarvindu Ghosh and Professor Dr. Somashekhar for joining us. And thank you, trainees and faculty members, for joining us.
Thank you.
Thank you.
Thanks all.